Good morning, colleagues. We are sorry for starting late, just some small technical hitch. But today we have a normal Friday session. Today we are doing experiences. Sorry. So today we have 5 panelists, and I'll do a quick round of introduction. You just unmute your mic, say hi to us to confirm that your mic is working. So start with Dr. Christine Karanjachege.
Good morning, everyone.
Dr. Karanjachege, unmute your mic, say hi to us.
Good morning, everyone. Am I audible?
Good morning. Dr. Il.
Hi, good morning. I hope you can hear me.
Dr. Muchella.
Good morning from Kisumu. Good morning. Can you hear me?
Good morning. I hope you can hear me clearly.
Good morning, everybody. Good morning, everybody. Good morning, everybody. We're looking forward to this. Good morning, Anne-Marie. Oh, thank you. We're looking forward to this webinar. So today we're going to be discussing experiences managing pediatric COVID. Sorry for starting late. I think we're just going to go straight ahead to our first presenter. That is Dr. Christine Karanjachege. Dr. Chege is a pediatric infectious disease specialist. She's a lecturer at Kenyatta University and is also working in the private sector. So Daktari is going to take us through a presentation on experiences managing COVID in the private sector. Karibu Daktari. We'll start sharing your slides shortly.
Put on.
We can hear you very well. Go ahead.
Thank you. Thank you. Are you able to put it on a slideshow so that the slides look bigger? But it's okay. We can still proceed the way they are. And I just want to look at the evolution of COVID-19 in children. It is not possible to cover everything in this very, very brief moment. And we've of course had a late start, but we can go through some aspects, and I'm sure we'll have a very robust Q&A. So we'll look at whether children can get COVID-19, how do they get it, how often are they hospitalized, what are our clinical findings, any risk factors for severe disease, clinical cause, and touch a little bit on the multi-system inflammatory syndrome in children. I will be looking more at global data, but it is reflective of what we have in our local situation. And I'm sure the other speakers will touch a bit on the local situation. Next slide. Next slide, please.
Doc, I'm trying to progress your slides. Just give me 1 minute.
No problem. Of age group in children. And we can see that this was the first one of those first studies carried out in China, looking at 2,000 pediatric patients, and they noted that 6 to 10 years comprised a majority of the cases. And of course, this is the age group that is very mobile, does not wear masks consistently. So they, of course, serve as spreaders. Next slide. So yeah, just hold it right there. How do children get COVID-19? Most of it get it from household exposure. That is from the studies carried out in 2020. But as schools reopened, we do really need to look at the data, because I believe that most of the pediatric cases now are getting it from school, especially in a primary level, and of course, even in the boarding schools. So we need our own local studies to show how most children are getting exposed. So this table here was carried out in families. You can see mother, father, and their siblings, and of course, grandparents. So the green represents those who tested positive before, and the yellow represents those who tested positive simultaneously. And then the red represents those who tested positive after their parents. So you can see that most parents tested positive before their children actually tested positive, meaning they were the source of infection to their family. And next. So just go back a little bit, stop right there. So exploring the severity of COVID-19 in children, let's first look at the potential markers for severe disease at admission. Some of these are not available in our setting, but most are available, especially in the private sector. So inflammatory markers at admission can tell you how severe COVID-19 is. So elevated CRP, procalcitonin, IL-6, ferritin, and D-dimers. Of course, clinical features like low SpO2 below 92, and GI symptoms are also features indicating the likelihood of severe disease. So now just looking on the left side, where we have the table that shows the gradient of severity of illness in the confirmed cases, we see that a majority, over 90%, are asymptomatic in children. But we have a low percentage being severe and critical. The majority of cases in children are asymptomatic, mild, and moderate. But again, another confounder is that some hospitals in the private sector especially tend to carry out universal testing for all admissions, including those just coming for elective procedures. So some of the testing there is even as asymptomatic is just an incidental finding. Next slide, please. Just the whole slide. Yes, right there. Thank you. So let's look at the spectrum of clinical symptoms in children. Remember that the symptoms in children and adults are similar, but children tend to get milder disease. So what I have highlighted there is that common in children, the two most common symptoms are fever and cough. The others occur in various degrees, some absent, some present, but we shall explore a few of them in greater detail. So the younger children tend to have more of a wheeze. And again, like this season, this being our bronchiolitis season, when it's cold, we've had a lot of wheezing in the young babies, but the older children have had more of upper respiratory disease. So next slide, please. Yeah, let's look at GI symptoms, because I know we have dwelt a lot on respiratory symptoms, and somebody will talk about that. But I want to say that GI symptoms can occur as a sole symptomatology in COVID-19 disease in children, the incidence being reported as 3% of the cases. So we can have symptoms like anorexia. I've highlighted anorexia because it's the commonest finding in children and adolescents with COVID-19 presenting as GI disease. Others are spread out as diarrhea, vomiting, nausea, abdominal pain, and very, very rarely GI bleeding. Now I have put acute, just go back to the slide, please. I've put back acute cholestasis, pancreatitis, and hepatitis as a finding, because so far I've been able to see 2 children, adolescents with cholestasis and hepatitis, unexplainable by anything else other than COVID-19. So that is something to keep in mind. Next slide. Yes, neurologic manifestations. This I'm looking at a multi-center study carried out in the US on children who are hospitalized with acute COVID-19 or the multisystem inflammatory associated with COVID. So of the over 1,000 and over 1,600 patients admitted, a majority of those who presented with neurologic manifestations had underlying neuro disease. So neuro disease puts you at risk of neuro manifestations in COVID, and only 8% had no underlying neuro. So how did they fare, these patients with the neuro manifestations? Thankfully, 88% of them recovered fully, but we had 12% having stay there, having life-threatening neurologic manifestations, which ranged all the way from stroke, encephalopathy, Guillain-Barré syndrome, cerebral edema. And what were the outcomes of these ones? 40% survived, and close to 30% died. And of course, there was missing data. So that is how it is with neurologic manifestations. Next slide, please. And so what I think that one just highlights the last bullet there tells us that the long-term neurodevelopmental outcomes of these children need to be explored further. Carry on the slides. Good. Cutaneous findings have been described. I don't have pictures of our patients, but I have some pictures there showing us the neurological manifestation, the dermatological manifestation in the COVID. So we have the acro ones. Acro just means involving the hands and feet and digits. So we can have them being as vesicles, as papules, as what we call pseudochilblain, which are those on the first picture there on the left. And we can even have arterial-like lesions. So those are acral. I've shown there that the more widespread the lesions are to progress to other parts of the body, the most likely the severe cause of the disease is. And this severity of dermatological lesions is mostly described in adults. Next slide, please. So that slide just shows the generalized lesions. I've highlighted there the livido or necrotic kind of lesions that tend to occur in severe COVID and more so in adults and the elderly for that matter. Next slide. So what are the risk factors for severe disease? The comorbidities that are associated with severe disease are many: the cardiovascular, neurological, respiratory, hemato-oncology. Of very great importance in our hemato-oncology is sickle cell disease, genetic syndromes, endocrine, and endocrine here would highlight diabetes type 1, which is there in children, obesity, prematurity, and then we can have severe disease in children with no comorbidities, although rarely, but it has been described as well. So cardiovascular in this study accounted for the majority of severe disease. Next slide, please. And how is the clinical cause? What are the expected outcomes from this study? I want us to look at down there at ICU admission and mortality. And this was a systematic review of pooled studies. Looking on the left side, we can see the multisystem inflammatory disease. How did these children fare? So these children who present with that syndrome, a higher proportion of them compared to severe acute COVID got admitted to ICU, 47% compared to 22%. But unfortunately, a higher proportion with the MISC also died compared to the overall severe acute COVID. So MISC is a very high risk factor for mortality. Let's look at this study, which also explored low middle income data and high income data. Now, the reason for putting this here is because the findings need us to explore some aspects in our care. So this study also showed that a lower proportion of cases in the low middle income countries were admitted to ICU, 9% compared to 26%, but goes on further to say that deaths among hospitalized children in low middle income countries were higher compared to the high income countries. Those are very sobering data, because it means then our critical care is not adequate. Next slide. Long-term symptoms after COVID-19. What is the data showing? So this study, which was carried out over a period of 6 months, exploring the outcomes of children who had tested positive to look for long COVID, showed that there was a low prevalence of symptoms that could be attributed to COVID. So this needs to be explored further, but as at the moment, the long COVID syndrome is not that much prevalent in children. Next slide, please. A few things on MISC. This is a syndrome that has been described from last year, 2020, first in the UK. And it was shown that it actually seems to be more of a post-COVID syndrome, meaning that it could be immune-mediated, unlike not as much related to the virus itself. It's quite rare in less than 1% of children. Next. Next slide, because I really don't want to dwell on that, because I'm seeing my time is even up. So what I want to tell us is that MISC can be confused with Kawasaki syndrome. And just to tell us about Kawasaki syndrome, which is one of the hyperinflammatory pediatric conditions that we see and miss out on. And we always take the opportunity to talk about it whenever we can, so that it's always an index of suspicion in hyperinflammatory conditions in children. So it's acute self-limiting vasculitis of the medium arteries and predominantly affects children. The main risk with Kawasaki is the long-term effect on the coronary arteries that may lead to acquired heart disease. It presents with high fever and mucocutaneous inflammation. Next slide, please. Another two categories of hyperinflammatory conditions to be considered as differentials in MISC is toxic shock syndrome associated with severe bacterial infection and macrophage activation syndrome. That is a kind of, it causes blood dyscrasias following hyperinflammatory reaction to either autoimmune, infectious, or malignancies, which can also be a differential in MISC. Next. Now I am winding up. What I just want to show on this slide that I have highlighted is that the incidences of Kawasaki disease seemed to have increased in 2020, and MISC accounted for a majority of this. Next. So to differentiate MISC with the other hyperinflammatory conditions that I have mentioned, we want to show that MISC generally occurred in older children than the typical Kawasaki disease and had more respiratory, GI, meningeal, and cardiovascular involvement, meaning had a more multi-organ manifestation than Kawasaki disease, more severe coronary disease, higher level markers of cardiac injury like troponin, and more robust hyperinflammatory response when you look at the inflammatory markers. Of note is that most patients, actually almost all, tested negative for PCR for SARS-CoV, but positive for the antibody. More severe disease cause, resistance to the conventional treatment for Kawasaki, which is intravenous immunoglobulin. So they needed adjunctive steroids, and they had biochemical evidence of the macrophage activation syndrome. So more severe cause. As I wind up, just go to now the next slide. Yeah, okay, carry on. Yeah, so those circles just up there just indicate the difference between MISC and the other syndromes, just to highlight the inflammatory markers and the blood markers. Next, because I've already mentioned, I won't really go into depth with that. That's, yeah, just skip right through those because they are just showing us what I have said. Yeah, just carry on. Carry on till the end. I believe we shall have these slides with us. Okay, now hold it right there. What have we seen in Kenya? I just want to highlight about 10 aspects of the Kenyan situation in a snapshot. One is that early last year, and I believe Anne-Marie and I had a presentation on this, we noticed a surge in Kawasaki disease-like conditions in our settings just before the pandemic was declared. So that leaves us to wonder whether already we had the COVID circulating. And then we have also noted during each wave of the COVID, we have had surge in acute respiratory infections, both upper and lower, and especially any time that schools are opened. Another thing that we've noted is also an increase in the gastroenteritis also. We noted a few cases similar to those that I had described. We noted a DKA who was admitted recently in the private sector. Whether this was an incidental finding or not remains to be researched. We noted a case of thromboembolism, which could not be explained by anything else other than COVID, but the patient is on heparin and is stable. We've noted quite a number of dermatological manifestations, and especially papular manifestations, a lot of oral lesions that can't be explained by anything. The hepatitis that I talked about, we've noted. Unfortunately, we had a mortality in an obese teenager in the private sector. So that has been the spectrum. And we've also had incidental cases when you're testing a patient going into surgery, but those have been asymptomatic for COVID. So I will end there. And just on a word of note on the key takeaways is that children can get COVID-19. So we need to be very careful when we are examining them in the outpatient setting. Please ensure that you do not unnecessarily subject yourself to exposure by examining throat without adequate PPE. You need to wear your goggles or your face shield in addition to your mask. And remember that they get it mostly through household contact, especially the very young non-school going one. So any child with you see with an acute respiratory infection or GE, please find out if the household contacts are unwell, because that gives you an index of suspicion. Children are less hospitalized than adults. They recover well, but their symptomatology is similar. Certain comorbidities put them at risk of severe disease. So be very careful with your list of special needs children, the sickle cell children that you're caring for, the diabetics that you're caring for. Please have a close eye on them. And then remember that children, most of them recover fully, as we have seen. So in our treatment of children in the outpatient setting, we do not routinely test all of them because it would mean that you spend your whole day testing. In my practice, and I don't have data to inform my practice, I mostly test those who show severe symptoms that would need to go into the ward. Otherwise, the rest of them we manage as acute respiratory infections, acute gastroenteritis, as you would, and then keep a close eye on them. And then now, if there are any adults affected in the house, you send them now for testing, and encourage the adults in the house to all get vaccinated, because that is how, of course, we protect people from severe disease. Thank you very much. I will end my presentation there, and see you later in the Q&A.
Thank you very much, Dr. Christine, for that excellent presentation. We hope you'll be available later for the Q&A. In the meantime, if you have any questions, you can start to put them in the Q&A box. We'll answer those that we are able to, and then we can answer a few live at the end of the session. Our next presenter is Dr. Maureen Muchella. Dr. Muchella is a consultant pediatrician working at the Obama Children's Hospital at Joe TRH. She's just going to share with us their experiences, because we know that area was the epicenter of one of our later epidemics. Karibu sana, Dr. Maureen.
Thank you. Thank you for the kind introduction. So I'm going to share mainly about our experiences. Mine is not going to be such a technical presentation, just what we experienced here. Next slide. So that is our hospital. For those who've never been in Kisumu, the pediatric hospital and the isolation center are towards your left, the right of the screen. Next slide, please. So by way of introduction, JOTRH, the Jaramogi Oginga Odinga Hospital, it's a teaching and referral hospital, and it's been a referral center for a long time, way before the change of that name. And it has a catchment area of more than 5 million people in 10 counties that are surrounding, mainly in the Western and the Nyanza, former Nyanza regions. And for our facility, I only took the data for the children that were tested. The total number of adults that were tested were so much more than this. But the total under 20 years tested were 1,000, slightly more than 1,000, with the total positive who turned COVID positive were to be 149, with equal male and female ratio. And total admitted were 9. So you see, we have very limited experience, because the numbers who were admitted were actually very few. And of those who were admitted, only 3 were actually put on oxygen. The ones that were tested mostly were tested prior to going to surgery. And then, since nobody knows what to do with them, they're just admitted to the COVID ward to see if they'll test negative after some time, but they did not have symptoms for most of them. So 2 children had in our unit tested positive during admission for other illnesses, but since they were having no respiratory symptoms, no effort was made towards treating COVID pneumonia. They were just treated for the indications that they were admitted for. So as I reiterated before, we have few pediatric cases, so very humble experience we'll be sharing. Next slide. So I had wanted to present one of the patients who had a more severe manifestations, actually the only one who had one of the severest manifestations of COVID. So we admitted a 4-year, 8-month-old male who stayed with us for 26 days, resides in Obunga, which is mainly a slum area. And by the time they were admitted around May, by that time, we already had community transmission. So there was no history of travel or exposure to anyone with COVID pneumonia in the household as reported by the family. This was the first admission, and this child was not known to be unwell. The complaints were a 3-day history of vomiting, loose stool, fever, and joint stiffness, a complaint which we later came to find out there were convulsions, actually tonic convulsions, that the mother reported. So they presented a little bit late. They reported to be vomiting everything, had poor feeding, but the loose stools were around just 1 to 2 episodes in a day. The family did not report any cough or difficult breathing, but apparently had taken erythromycin as pre-medication 2 weeks within prior to the date of admission. The other history was mainly unremarkable. Next slide. So at admission, the child was sick looking, had a tinge of jaundice, was mildly pale but had no edema, had sunken eyes but had warm extremities and no other signs of dehydration. The weight was appropriate for age at 15 kg, and the vitals were initially stable. The respiratory rate was 26, temperature was 36.4, with a heart rate of 111 and saturations of 98 on room air. The initial findings in the respiratory, cardiovascular, abdominal systems were unremarkable. In the central nervous system, which was the system of note, the child was only responsive to pain, but had no meningismus signs, had a soft neck, but had hypertonia both in the upper and lower limbs, but the pupils were equal and reactive to light. Initially, there were no skin findings. So a diagnosis of severe malaria based on the area we are were made based on the history that was given and possible acute bacterial meningitis since the child had convulsed just within 1 hour of admission. Next slide. So these are investigations that we did on the day of admission. The full hemogram had a moderate anemia with a microcytic hypochromic picture. The WBC count was normal, but the lymphocytes were elevated, which was not in keeping with the presentation of COVID. Normal platelets and the urea electrolytes, creatinines were basically normal, and except for a slight hyponatremia at 130. The liver function tests had raised aspartate transaminase levels and the total bilirubins as well, but the alanine transaminase was normal with normal proteins and albumin levels. The malaria smear that was taken demonstrated no malarial parasites, and the CSF studies that were done later when we received the results, actually it was clear and it was basically normal. Radiological studies that were done were CT scan of the head, which were also reported to be normal, and the chest X-ray, which were reported to be normal. So at this point, we were a bit confused, and at this point, we were reaching out to our infectious disease colleagues in Nairobi. Next slide. So initial treatments that was begun, despite the negative blood slide, we had already started treatment for malaria with artesunate as prescribed in the guidelines, high-dose ceftriaxone for the meningitis. Later on, as the child's status was not improving, we started acyclovir because the consciousness level was rapidly deteriorating. Anticonvulsants, diazepam in the emergency phase, but we maintained later with phenobarbital after loading it, and we put zinc sulfate because of the history of diarrhea, though the diarrheal episodes did not continue while the child was admitted. Next slide. So within 1 hour of admission, I alluded to this before, there was rapid deterioration in the clinical status of the patient. A patient who came was noted to now have generalized tonic seizures. Several episodes were recorded. The appropriate treatment was started. And the second day of admission, now we started seeing fevers, temperatures ranging between 38 to 39, and the consciousness state has now deteriorated, and it was ranging between 5 to 8. Now, on the second day of admission, small, I'd call them papules, on the scalp were noted, but they were not anywhere else in the body. On the third day of admission, the child now began to develop shock. It was fluid responsive, but had to be resuscitated twice, became hypoxic on room air, and started to have now chest findings. There were crackles on auscultation, and now oxygen was started on the third day of admission at 1 liter per minute. He was saturating at 96 on that. So we started considering a possibility of ICU admission, and as the COVID PCR was actually done as a requirement for ICU admission, we had not thought of COVID in this child before. So next slide. So on the 7th day of admission, we got back the results. The child had positive results, and now the panic started. So we continued the treatment that we had, but now on consultation, we added azithromycin, dexamethasone, vitamin C. The child was already on zinc sulfate, and admitted the child to the transferred the child to the isolation ward, since now we had the COVID positive. Again, it's just a small unit, so it's not very equipped, but now we had to transfer since the test was positive. Next slide. So the progress in the ward, as I've alluded to before, the first 7 days of admission, there was deterioration in the CNS status of the patient. The child remained unresponsive with persistently low GCS. But after beginning the azithromycin and the treatment in isolation, the child quickly, within 4 days of admission in that center, I don't know whether it's a treatment or the environment, the child's status started to improve, actually to 15 out of 15 by day 6 of admission in isolation. And on the treatment that they were given, they were weaned off oxygen on the day 6 of admission in the isolation ward. And on day 15, after admission in the isolation ward, a repeat COVID test was done, and it was negative, and the child was discharged back to the pediatric ward. In the pediatric ward, we noted that the child, who was previously verbal, would not talk much and had an unsteady gait. Otherwise, in that was the immediate recovery period. But otherwise, when we followed up the child is actually currently joined school and is no longer on active follow-up, and the parents report no change in behavior or anything that would be of concern. Next slide. So we still wondered what, because we had not had much experience with COVID, and we wonder if our child would fit the definition of the inflammatory syndrome as described by the WHO, because our child was 4 years, 8 months, and was having episodes of hypotension, had acute gastrointestinal problems on presentation, and unfortunately we could not be able, and a positive COVID test, but we're not able to do at our center any markers of inflammation. So we didn't quite follow up on that. So the next slide were points to ponder. Next slide, please. Yeah, this goes to the other panelists as well. And I don't know about any experience that the other part of the team have had with convulsions and COVID-19. But as we've seen in the previous presentation, that they are neurological manifestations, but the type of convulsions have not actually been described well. Thank you so much for listening.
Thank you very much, Dr. Maureen, for that excellent presentation. In terms of comments, you said you're humbly presenting. I think COVID is humbling all of us. Every day we are learning more about it. As we get in, even into the presentation of vaccines, we'll see there are so many unanswered questions. So we really appreciate the experience you've shared with us. As you talked, and I know we had discussed this patient at some point, it actually seems as if this child does fit aspects of MISC, and that leads well into the presentation we're doing next, because we're going to go into a bit of detail on MISC. Reason being, we're making a lot of this diagnosis in hindsight when you think about patients later. So we really want to raise the index of suspicion and enable clinicians to recognize it, because there are certain specific treatments that will actually improve the survival and outcome for those children. Regarding the management of acute COVID, I just want to mention that the only proven thing, and this is really based on adult studies, is the use of steroids, specifically dexamethasone for the children who may need supplementary oxygen and have severe respiratory symptoms. Because we know the main presentation in acute COVID may include more of the RESP symptoms than the children who have MIS-C. However, for children, because again, as they come into hospital, this could be the usual community-acquired pneumonias. So while antibiotics are not part of the treatment for COVID, so you're not going to give an antibiotic to a stable child who you're able to discharge home and observe, I think it is still okay for you to treat a child coming in with severe pneumonia requiring admission with our usual antibiotic protocol, and they may also benefit to dexamethasone in addition to the oxygen, supplementary oxygen. Regarding the issue of supplementary vitamins, unless really a child has a deficiency, like the children who we know have vitamin D deficiency and have rickets, they may not really play a role because I was hoping Dr. Christine would mention this. We are seeing children, particularly those leaving outpatient services, having a whole list of prescriptions with that azithromycin, with a vitamin C, with a vitamin D, and all these are really not necessary. You can just give some symptomatic treatment to manage perhaps the fever and myalgia that the child has, with advice on the danger signs that should bring them back to hospital. So thank you so much. We're now going to go into the next presentation, which is going to be looking in detail at the MIS-C. Reason being that though this is a very rare presentation, it needs a high index of suspicion. And we're going to see that because this child may not even have a positive PCR for COVID, really the clinician needs to be able to recognize it. So we'll just get straight into the presentation. And I'm starting with a case. This is a child who was in one of our hospitals. An 11-year-old male who had no significant previous history. He came in with a 5-day history of fever, sore throat, cough. He had red eyes and he had a truncal rash. The child was having worsening dyspnea and intermittent chest pains. Prior to his admission, he had been seen in an outpatient and received a 4-day course of amoxicillin, clavulanic acid, and ibuprofen, but there had been no clinical improvement. His vital signs at the outpatient were a tachycardia of 90 per minute. He had a blood pressure of 105/61, which was normal for age. The child was tachypnic with a respiratory rate of 40, and his oxygen saturations were 96% on room air. Notable in his physical exam was bilateral conjunctivitis, a mucositis, and generalized rash, as well as peripheral edema and a delayed capillary refill of 2 to 3 seconds. The child also had epigastric tenderness. So these are the initial labs on presentation, and notable there is a normal white cell count of 11, but there was a lymphopenia of just 5%. The child also had elevated creatinine at 269 and an elevated urea at 20.2. A C-reactive protein was also done at that point, and the C-reactive protein was 254, which was elevated. So the working diagnosis at this point was sepsis with acute kidney injury, but the clinicians at that point actually thought of COVID, and the child was admitted to the isolation ward pending COVID-19 results, where he was rehydrated with IV fluids and started on IV ceftazidime to cover for the sepsis. Overnight, the child's clinical condition deteriorated and he developed respiratory distress. He also had hemodynamic instability with tachycardias of up to 140 beats per minute. His peripheries were cool and he had weak pulses. So he was actually going into hypovolemic or septic shock, and he had lower blood pressures. They were now in the range of 67/39, which is low for age. The child was also anuric at this point. So he was transferred to PICU with an initial diagnosis of septic shock and placed on high flow nasal cannula at 40 liters per minute with an FiO2 of 60. He received a single bolus of fluids at 20 mL per kg, followed by maintenance fluids. He was also started on inotropic support peripherally and then centrally once a central line had been placed. So based on the findings of the fever, the rash, conjunctivitis, and acute kidney injury, a diagnosis of MIS-C was suspected. And further inflammatory markers and an echocardiogram were requested. This was a child who had been admitted at a private facility. So progression in the labs, so the D dimers requested were elevated, his troponins were also elevated, ferritin was markedly elevated. Liver function tests were notable for a slight increase in his AST, so he had a bit of a transaminitis, and the blood gas done at that point showed a primarily metabolic acidosis. In his clinical course, the child was then left on high flow nasal cannula and was not intubated. The echo done showed cardiogenic shock. The heart was structurally normal. And remember, this is a child who was previously well. He had a low ejection fraction in the 30s, and this was on inotropic support with adrenaline at 2 mics per kilo per minute. He had mild aortic regurgitation and moderate tricuspid regurgitation. There was no evidence of coronary aneurysms. So at this point, intravenous immunoglobulin was started at 2 grams per kilo. He was also given steroids, methylprednisone, and low-dose aspirin. Once the child was given IVIG, there was dramatic improvement from the cardiogenic shock. And over the next 24 hours, the adrenaline was weaned off. He was taken off the high-flow nasal cannula to nasal prongs, and his acute kidney injury also started to resolve. So there was also an improvement in his labs. You can see now the creatinine fell from 269 to 116, and the urea was also reduced down to 15.1. And his blood gases also improved with a lessening of the metabolic acidosis. So his clinical course was unremarkable in the PICU post his IVIG and steroid treatment, and he was discharged to the ward. This was 3 days into his admission. And in the ward, we can see further improvement in the lab parameters as indicated there. In the ward, the child remained hemodynamically stable. He was not in respiratory distress, was alert, ambulant, and he had normal urine output, and he was discharged home after 3 days. He completed a 7-day course of steroids followed by 2 weeks of steroids with a taper and a 6-week course of aspirin, and he was planned for a repeat echo after discharge. That repeat echo was actually not done, and the patient returned 2 days post-discharge with complaints of palpitations. And on examination, he had a tachycardia with a heart rate over 100. His blood pressure was okay, and he was well perfused. His oxygen saturation tracing, we noticed that the rhythm was not normal, and an ECG was then performed, which I'm just going to project there. And what it's showing is some premature ventricular contractions, which have been circled there for us to appreciate. Yeah. So his electrolytes done were within normal limits, and the patient was admitted overnight for monitoring in the pediatric HDU. Despite a low normal magnesium, he was given boluses of 50 milligrams per kg twice, and the PVCs reduced after the child received the magnesium. He remained hemodynamically stable, and his repeat ECG was normal, and his repeat echo was normal. And the ejection fraction had improved from the low 30s to 66%, and there was still no evidence of coronary aneurysms. So we're just going to get into a discussion on MIC, just so that we're able to recognize this important syndrome. So like Christine and the other presenters have said, most children are asymptomatic, or they only exhibit some mild symptoms that don't need any medical intervention. And in the early studies, there was one of 171 children who had confirmed COVID, and only 3 of those children required intensive care admission, and only 1 death was observed. So why do we want to talk about this important syndrome? Yeah. So this slide is showing the spectrum of illness that children may have. On the left, we can see the children who have acute COVID, which is the more common presentation. And you see it is mild, where most children may have no or very mild URTI, similar to their normal viral URTIs. And a small proportion may get acute severe COVID, where they have a positive PCR and have more severe respiratory manifestations that may require hospitalization or supplementation of oxygen. And then on the other end of the spectrum, you have COVID-associated multisystem inflammatory syndrome, which is a febrile inflammatory state. Like we've seen, there is some overlap with Kawasaki disease. And then we have those who have severe MIS-C who are the focus of this discussion. This will actually be a very small proportion of children. Yeah, some studies describe it as less than 1%. But you realize that when you have a large number of children who have COVID, then the chances of having a child with MIS-C are greater. As we've said, this syndrome was first recognized in the UK, where they had 8 severely ill patients presenting with this hyperinflammatory syndrome, and since then has been reported in several other countries. I don't want to go through that because Christine shared the same slide. Yeah. So what you need to note about MIS-C is the first curve there, the one in blue, is indicating a rise in cases in the general population. Please go back to the previous slide. Okay. So that curve, the blue curve, is showing a rise in cases in the general population. And you'll note that the cases of MIS-C tend to be seen about 4 weeks after that. So there is a lag between your peak of COVID and recognizing cases of MIS-C in children, because this seems to be a post-COVID hyperinflammatory syndrome, as we're going to see. So what is the definition? I'm going to share the WHO/CDC definition. There's one that is also used by the UK, but they're fairly similar. So it's a long definition, bear with me. So the first criteria is the age. So it's children and adolescents aged 0 to 19 years who have fever lasting longer than 3 days. And then they will have any 2 of the following clinical presentations. So they will have rash, or a non-purulent conjunctivitis or mucocutaneous inflammation, which could be oral or acral, that's happening on the hands or feet. They will present with hypotension or shock. They will also have features of myocardial dysfunction, which could be a pericarditis, valvulitis, coronary abnormalities, so echo is an important investigation. There is evidence of coagulopathy as evidenced either by a raised prothrombin time, an elevated INR, or elevated D dimers. And many of the children will also have acute symptoms of gastroenteritis. The other criteria is they should be signs of inflammation, meaning an elevated CRP, ESR, or procalcitonin. And you should exclude any other obvious cause of inflammation, bacterial, staphylococcal, strep syndrome, because you realize that definition we've given, many children actually present with GE and shock, and they used to even prior to COVID. The last criteria is that there should be evidence of COVID infection. So either you have a COVID positive PCR, you have a positive antibody test, or there is evidence of the child having been exposed to COVID. Here, I just want to emphasize that the MIC definition does not need you to have a positive PCR. So it really needs you to carefully take a history and see, had members of the household, adults in the household, either been diagnosed with COVID? Did anyone in the household have symptoms that were suggestive of COVID? Because we know antibody tests are not readily available, and only a small proportion of children will actually present with a positive PCR. So I'm just going to share data from the US. This was a study done across 26 states in the US. And we want to look at the clinical characteristics of the children who presented with MIS-C. It was a total of 186 patients, and only 131 of them had lab-confirmed SARS-CoV-2 infection. So those who had a positive PCR were 73, which is just about 55% of the children who had confirmed infection. So over half of them, their PCRs were negative. 59% of the children were male. As you can see, it's a disease that tends to occur in the older children. Very few of them were less than 1 year old. So majority of the children were in that age group between 5 and 19 years. In terms of the ethnicity, many of the children were non-Caucasian. Yeah, so in that particular population, some were Hispanic and some were Black. In terms of the underlying conditions, 73% of the children were actually previously healthy. Of those who had an underlying condition, respiratory and cardiac seem to be some of the conditions manifesting, and then obesity seems to be quite a major risk factor, and about 8% of the children were actually clinically obese. In that slide, I just want you to look at this part where we're talking about organ system involvement. And a lot of the children, 71% of them actually had 4 or more systems involved. In that population, 2% of the children died. Majority of them had been discharged alive by the time the study was being published. So in the same study, if you look at the terms of, in terms of cardiovascular involvement, a high proportion of children, 80% of them had some form of cardiovascular involvement. So markers like troponin and BNP were elevated. For the children who had echoes performed, the finding that was most common was a reduction in ejection fraction at about 62%. In terms of non-cardiovascular involvement, we want to highlight here that gastrointestinal involvement is extremely common. And we are seeing the same thing with our children. Even if they don't present with major respiratory symptoms, a lot of them have GI. And again, in the slide below that, it is highlighted that over 75% of the children will have some involvement of the gastrointestinal system, be it abdominal pain, vomiting, diarrhea. In fact, some children have even been taken to theater being suspected of having an acute abdomen and had appendectomies performed on them. This is a different study still from the US in a larger proportion of children. In this particular study, which had 662, majority of the children were male. Again, preponderance of Afro-Caribbean children. What I want to highlight here, Christine talked about us having lost one adolescent we suspect who had MIS-C. Obesity seems to be a major risk factor. 50.8% of the children in this particular study had obesity. And there are several reasons why this may be. It is thought that the adipose tissue could actually be storing the inflammatory cytokines. The adipose tissue could also be producing some pro-inflammatory cytokines. And these children are also more likely to have some respiratory compromise. Fat tissue may also have a higher proportion of receptors for the SARS-CoV-2, although these are all things that are under investigation. So perhaps in our children who have obesity, that needs to be one of the things we look out for. So what are the signs and symptoms? Persistent fever. We've talked about Kawasaki-like features, including the conjunctivitis, red eyes, swollen feet, and in some children, coronary enlargement. In the next slide, I'm sharing slides with permission from one of the patients we saw here in Kenyatta who had that Kawasaki-like syndrome. What I want you to appreciate is the Truncal Rash. This was taken some days into admission when the patient was more stable, but she had this maculopapular rash all over the body. Parents allowed me to show this slide and show the child's eyes because you can see she had a purulent conjunctivitis. She had a bilateral conjunctivitis and all this desquamation and mucositis. And this is actually more than 10 days into admission when it was actually improving. So we are seeing these children even in our own population. So we've talked about the symptoms, evidence of organ dysfunction. We've talked about GE being a common symptom. Sorry, I'm trying to rush through these slides because there's been a bit of repetition. So in this data set, for example, 100% of the patients had fever. So when you have that older child who has come in with persistent fever, many of them are moving from one outpatient to another, being treated with antibiotics, and there is no improvement. And then you have a sudden deterioration in that child. Either they go into shock, they present with some abdominal pain, they start to present with some respiratory compromise. Please think SARS-CoV-2, even if their PCR is negative. So if an echo is performed, like we've said, a lot of these children will have an abnormal echo, and the main thing is a decrease in the ejection fraction. Other things may include the aneurysms like we've talked about, or even pericarditis. So to reiterate, look at the age, persistence of fever, presence of elevated markers of inflammation. So you may want in that child who is looking a bit sicker to keep track of their CRPs, even on an outpatient basis, and then look at that temporal relation to SARS-CoV-2 infection. I think that should be the end of my presentation. Let's see. I won't go into this. Dr. Christine had already talked about the differentials. I think we all had the same idea of what we wanted to share with our audience. So we've said that MIS-C typically presents 3 to 4 weeks after the acute SARS-CoV-2 infection. Many children will be negative by PCR, but positive for the antibody. And this suggests that the illness is mediated more by development of acquired immunity rather than direct viral injury. And it is like a delayed antibody-mediated dysregulated host immune response. Yeah. Those are the labs that you may want to do on your patient. They may present with lymphopenia, thrombocytopenia, neutrophilia, and we've talked about the other markers. Yes, good. And that's my references. So now I want to hand over to Dr. Real, who is our critical care specialist. He was actually the primary caregiver for the child who we presented in these slides, who then did well. So Dr. Real will just run us through the care of these critically ill patients. Dr. Real is a consultant pediatrician. He's a lecturer in the Department of Pediatrics at the University of Nairobi. He's also the consultant in charge of the critical care unit at Tempisha Hospital, and a very useful person to know when you have children who need critical care. Karibu, Dr. Real.
Thanks, Anne-Marie. I hope you can hear me well. And can you see my slides?
Yes, we can, but you need to put them as slideshow.
Okay, perfect.
There we go. Thank you.
All right, so yeah, thanks. So I'll just add on to what Anne-Marie was talking about and go over some of the critical care management that we've had to deal with, which fortunately hasn't been too much. So what do we do in terms of management and what I've divided it into is what we see severe acute COVID and then talk about the MIS-C syndrome and what the treatment management is in those cases. So to be honest, at the end of the day, COVID is a virus and treatment is really supportive. Most children tend to improve with just supportive care. Then we, as others have mentioned, many are asymptomatic with just really mild disease. And even those that get to severe point, which is a very small percentage, actually recover with just supportive care. And recommendations essentially for critical care point of view when those kids who are really severely ill and end up in ICUs is essentially the same as we would do for any other critical care child. Yeah, we know that this disease is, and like's been mentioned, that gastrointestinal symptoms are quite common, even with the severe acute form of COVID, that rarely does it progress in children to severe hypoxic respiratory failure, and we're thankful for that. This may change with different variants coming, but we hope it doesn't. So what do? We start off with basic supplemental oxygen. I think this will be a repeat for a lot of the folks in listening to the presentation, but starting off with the low flow nasal cannula, and then if your saturations are still a problem, then face mask and reservoir to give you much more higher FiO2. And then if you are fortunate to be working in a place where high flow nasal cannula is available, then that is just really an excellent way to actually deliver a high amount of oxygen with the flow required to help with work of breathing. Having said that, we've had very few patients who've needed to progress from high flow nasal cannula to invasive ventilation, and primarily feeling that those children had COVID-19. The ones that did, again, the recommendations are to follow what we would normally do for other critically ill children, and follow the Palisi guidelines for pediatric ARDS. If someone does get ventilated, targeting low tidal volumes, individualizing the positive end expiratory pressure. So just really targeting a PEEP to give you the right oxygenation. And then prone positioning, as we know from adults, has been quite effective with hypoxemia, especially in relation to COVID-19. From a cardiovascular standpoint, again, following the guidelines that are out there in terms of fluid resuscitation, that includes the WHO, the ETAT guidelines, and surviving sepsis guidelines, should you be fortunate enough to be in a place where pediatric intensive care support is there. And then really monitoring for this cytokine release syndrome, which causes this massive inflammatory response that results in sepsis and shock, that then will probably require some vasoactive medications, albeit adrenaline or noradrenaline or dopamine, if that's available where you are. Fluid electrolyte management, the children we've had to deal with are again the ones who got significantly dehydrated from a gastroenteritis syndrome. Empiric antibiotics are rarely needed, especially in the severe acute form. Like I said, it's a viral infection. Bacterial co-infections we know are very infrequent, so antibiotics are not needed if you're sure about the diagnosis. We know from the adult literature that COVID-19 does give you a hypercoagulable state, and risk for thrombotic complications are there in the adult world, although they've not really been well defined in children. And to be honest, we base it on a case-by-case basis whether we're going to give them low molecular weight heparin or not. Antiviral agents, again, adult world using it to some extent. Again, I would be very reluctant to do it in children, as we haven't, firstly, I don't think we've had those kind of cases where we would be accessible to that kind of medication. But again, lack of data would mean that I would be very reluctant to give it. So steroids, where do we lie with steroids? We know that the adult world is very, from the recovery trial, there's good evidence that steroids are associated with decreased mortality. The trials in children are still going on. But for severe COVID and those who are requiring increased amounts of oxygen from and mechanical ventilation, I would be inclined to give them steroids just based on what evidence is out there at the moment. I would not continue more than 10 days, and I would usually stop them for those children who get better and are discharged before a 10-day period. So dexamethasone is what the trial's been done on, and that's what we use. I think you can find an equivalent dose of 1 per kilo of prednisolone if you were to do it if dexamethasone wasn't available. Tocilizumab, which is a monoclonal antibody that reduces inflammation by blocking IL-6 and hence reducing that cytokine storm inflammatory response. The data in adults is out there with specific recommendations at what point you should give it. Children, again, there's not much, and I would be very, very reluctant to give it. So, I mean, I've separated it out, the presentation, into severe acute COVID and MIC management. And the reason for that is actually, I think even the children we've seen in our ICU, we screen everybody who comes into our ICU. And we are often surprised that some of them have COVID because we haven't seen really any change in the type of admissions we're getting to the ICU. So my gut feeling is that a lot of these children, majority of the children, are not sick because of their COVID-19, but are sick and we happen to find COVID-19. And hence recommendations and really just to treat a ill child like you would normally treat a critically ill child, if that makes sense. I think the only thing that we consider once we get COVID-19 and we have someone on oxygen that we would change is to give steroids as described here, and really consider whether the COVID-19 is really the factor that's making the difference or making the child sick. So this, just to add on to what Anne-Marie said in terms of management of MISC and where we stand on that, and how we can apply what the adult, what the developed world is doing, and how we can use that in our setting. So the thing we worry about the MIS-C syndrome is basically that these children can rapidly deteriorate. Okay, so we've gone through the different diagnosis and how you diagnose it, which is actually the biggest conundrum in trying to figure out whether this child has MIS-C, and like Anne-Marie said, to be very vigilant and looking for it is when you'll find it. Those kids who present who are severely ill do present rapidly deteriorating with cardiogenic shock and requiring inotropic support. There's loads of children described in the developed world who presented with left ventricular dysfunction, requiring even more cardiovascular support and afterload reduction to help their dysfunction. This is more of the same that has been talked about, but hemodynamic stability in these children, more than respiratory compromise, has really come out, and treating that accordingly. So if you have severe LV dysfunction, giving inotropic support, diuretics, things we do for heart failure, is what we ended up doing for some of these children that we've seen. Serial echo assessments, again, looking for not only aneurysms, but looking at the cardiac function, and then how to manage it from that point. Monitoring things like BNP and troponin levels. It's actually possible because Adult World does it a lot, and I think they're readily available even in the public sector. The question now becomes on how do we treat that? So, from an ICU standpoint, you support the heart as much as possible. I try not to intubate these people unless we really are at a point where cardiac function is so poor that that intubating may help the cardiac function in itself. But we'll talk a little bit more about the treatment, because I think no matter what we do in ICU, from a supportive care point of view, if we're not treating the underlying disease, we'll never win. So I want to just really spend some time talking about IVIG and steroids, and when to give it, and what the evidence tells us. In terms of antimicrobial, antiviral treatment, again, when we're talking about MIS-C, and this, I think it's repeating a little bit of what Anne-Marie said, was that antibiotics, if you have severe acute COVID, I don't think antibiotics are necessary. But when you have something like MIS-C and it's difficult to tell what exactly you're dealing with, I think an empiric antibiotic therapy is indicated, with cultures drawn and discontinued as soon as the diagnosis is confirmed. But to make sure that you're not missing septic shock and toxic shock-like syndromes out there. The role of antiviral therapy, again, I would not recommend it at this point. We just don't have enough evidence to be giving that. So IVIG, so we're going to talk mainly now about MIS-C, this treatment with IVIG and steroids, whether to give both, whether to give one alone, and what we can do in our settings, and what's the evidence out there. So when we talk about IVIG, we're looking at a 2 gram per kilo dose. What I would say is, and I will talk about the study that says that children who do have cardiovascular dysfunction, if you can get a hold of IVIG, it is worth giving to them from what literature we have out there. IVIG is extremely expensive, and obviously that's limiting to us. It can, if you have obese children or slightly older children, it can be a huge volume load. So dividing the doses into 2 and giving them over a 2-day period is probably recommended for especially those with significant LV dysfunction. For smaller kids, 2 grams per kilo wouldn't be that much volume, and can be tolerated quite well. So again, steroids. So we talked about IVIG. Steroids are not standardized. If IVIG is not available, I would give steroids for sure. and we'll talk a little bit about that as well. In severe manifestations, I would give IVIG and steroids. This is what we would consider as severe manifestations of MIS-C. So shock requiring vasopressors, elevated cardiac markers, if you have an aneurysm, persistent fevers, inflammatory and rising inflammatory markers, and an intravascular coagulopathy. So ideally, glucocorticoid therapy in addition to IVIG would be my recommendation. And I'll once we've gone through this, I'll just kind of go through the literature and let you decide what you feel as well. In less severe manifestation, which I won't spend too much time, you can give IVIG or steroids alone. The steroid dose, no matter what, would be 2 milligrams per kilo per day and divided into 2 doses. Most of the recommendations out there are that we continue giving steroids for at least a 3 to 4 week period. So even following discharge, to be tapered over that long period of time. So just giving you the literature that's out there, there are 3 really good observational studies. The first one was in JAMA. These are just been published over the last few months. And it's a French study that looked at 111 children. And again, I wouldn't go into too much detail, but some were with IVIG, some were with IVG and steroids, and some neither. This study didn't have anything with steroids alone, but others will. So what they concluded was that treatment with IVIG and methylprednisolone was associated with a more favorable fever course as compared to just giving IVIG alone. So they recommended a combination therapy, basically. The New England Journal trial that's from the US study, again, dividing it up into giving IVIG alone, combination, or glucosteroids alone. And what they found out is that a treatment where their outcome measure was cardiovascular dysfunction, and initial treatment with IVIG plus steroids was associated with lower cardiovascular dysfunction than compared to IVIG alone. Now, this international study is quite remarkable. We have countries from all over the world participating and providing data on how they managed children with MIS-C. And in this particular study, it kind of gave a little bit of conflicting evidence from the previous 2 studies, saying that actually there was no difference, no evidence really of recovery, whether you used IVIG alone, whether you used it in combination, or whether you used steroids alone. So where do we stand with all that? I think they were, I'll just go quickly through this, thinking about the time, but we know that it can, all 3 studies showed that a combination therapy will help fevers. All 2 US and French studies show that combination will help hemodynamic support if you have cardiovascular dysfunction. And then the international study kind of said that everything's good, no matter what you do, it helps everything. When you look at the analysis of that, you can see actually that the US and French studies tend to have much sicker kids in their cohort. They've had different primary outcomes, which may explain why there was a difference in findings between the international studies as compared to the French and US studies. Putting all that literature and evidence aside, I think what we have to do is try to see what's applicable to our setting. Now, if I have a child with cardiovascular dysfunction and I have IVIG, I would definitely give IVIG and the steroids. I know, I can understand that IVIG is super expensive, might not readily be available around the country. So I think steroids are your best bet, and I'm happy to take that international trial and say, actually, yes, in some institutions we don't really have IVIG, and steroids may or be as good, and that's what we've got, and that's what we use. I guess what I'm trying to say is that if you have IVIG and it is accessible, I would give IVIG and steroids with a long IVIG is just a single dose, whereas the steroids is given IV initially that can then be tapered to an oral dose over 4 weeks. And that's what I would recommend. Adjunctive therapies, again, nothing uncertain, nothing really in the evidence for children. I think just people have used it, but I don't think it's readily available here anyway. It's very expensive, and we don't know what it does, so I'll be very reluctant to use it. The other thing we have to think about, and this also comes from our Kawasaki literature, is that we tend to give children aspirin. Those children who have severe LV dysfunction with MIS-C should be put on at least aspirin. The recommendations say that if you have severe disease and LV dysfunction, aneurysms, or elevated D-dimers, you should think about giving a low molecular weight heparin in addition to aspirin. And those who have less severe disease, I've tended to give them just aspirin, but I think you have to individualize that and decide whether the risk of thrombosis and the risk of bleeding when you put someone on low molecular weight heparin, especially if they have a less severe disease. And I'll just reiterate what Anne-Marie said, like children can rapidly deteriorate. They can present with very, very mild disease, and they can present with and go rapidly into cardiogenic shock. So it's really variable. We don't really know much about it. We don't know what the long outcomes are going to be. So vigilance is the key. And then following the recommendations that are currently out there, which I suspect will change as time goes on. Follow-up is with cardiac, obviously. Even if you don't have, if you have normal function, no coronary aneurysms, I would still follow up, and the recommendation is in 2 weeks. If you have an aneurysm, obviously that would be more frequently. Outcomes, thankfully, if we find it, we detect it, we treat it, I think outcomes are very good, which is very fortunate, even from a cardiac standpoint. And the child we discussed, his recovery was phenomenal. I think within few hours after the IVIG was completed, his cardiac function improved from a clinical point of view, and he clinically drastically improved. So just kind of, I think the take-home message would be to be vigilant about the disease. Outcomes, like I said, the severity is there. You can see a significant amount of patients requiring a good amount of support, but if treated well, percentage who don't have a good outcome are very low. So I think I'll end there. I'm open to any questions. I think we have still a lot to learn about the disease, and we've got to keep up with the literature that keeps coming out, because what I'm telling you today may change in a few months. But thank you.
Thank you very much, Dr. Reel, for that excellent and informative presentation. I think in the course of your presentation, you've actually answered some of the questions regarding treatment that have come up in the Q&A. One that I may ask you just to speak about in plenary once Dr. Chaby has done his presentation is the role of aspirin. But I think I see quite a number of questions there on treatment that we may just answer in the chat. And if we have time, we'll address some of them at the end in the Q&A. So our next presenter is Dr. Maureen Chaby. He is a consultant pediatrician, and he works for the WHO as in the FRH cluster for nutrition. Karibu, Daktari.
Thank you. So in preparing for these sessions, we thought we'll finish. So in preparing for this session, Sorry, we were trying to sort that echo. I think it is now clear. So we thought we'll conclude by discussing two aspects of pediatric COVID, that is the issue of vaccines and the issue of the mother and the newborn triad, because several questions have come up around that. In terms of vaccine, there are some general considerations, and we've heard over and over again from the presenters that children and adolescents tend to have milder disease compared to adults. I think Dr. Chege presented that only about 15% of the total infections are from children. However, we also know that children can be infected, and we've had examples of quite some severe infections in children from the previous presentations. And more importantly, and of public health concern, children can spread this disease to their households, to their parents. And I think there was a table again from Dr. Chege's presentation that showed how children can be source of infection to the family. So based on this, there is that need to keep an eye on the pediatric infection. And when it comes to infections, what we know or what we have as evidence is that there is a demonstrated effectiveness and safety for children above 12 years. There are studies that have shown the efficacy and the effectiveness. However, to note is that the effectiveness is mostly inferred by the immunobridging based on a comparison of the immune response in this younger age compared to the older age, the 16 to 25-year-olds in whom the vaccine efficacy has been demonstrated. There are ongoing research to try and look for the same for the younger age, 6 months to 12 years, and I'll speak to this in a later slide. When it comes to country considerations, most countries have prioritized what they consider as the more prone populations, the older people, those with chronic health conditions, healthcare workers, and such. So in most countries, children are not prioritized for vaccines. What kind of guidance do we have out there? WHO guidance is that the Pfizer vaccine is suitable for use by people aged 12 years and above. But again, the consideration of those at high risk comes into place in this guidance. When you go to the UK, their guidance is almost similar to this, that the vaccine is it's for children aged 12 to 15 years can get the vaccine. However, for them, they put some caveats for only those who live with someone who is more likely to get infection, or those children with the predisposing conditions to, or who are at high risk of infection. In the US, CDC recommendation is for everyone above 12 years. Most of these national guidelines are based on the availability of the vaccines in this age group of 12 to 15 years. There is a link there to the considerations that the review memorandum of the CDC did, which has evidence that was collected for that age groups for that vaccine. In terms of the younger groups, there are two ongoing research on the Moderna and the Pfizer vaccines to evaluate safety and effectiveness of the vaccines in children 6 months to those less than 12 years. What is coming out so far, and these reports are expected sometimes next month to December. What is coming out so far is that these vaccines are actually safe at this age. Effectiveness, again, inferred, is that they are effective for that age group. Also, what is coming out is that the dosage is likely to be lower for this age group. Both of them are working with about a third of the adult dose. Remember, the 12 to 15, we are giving the adult dose, but for this young age, what is coming out is that the dose will be slightly lower. So the expectation is that by about September to December, we'll have this evidence, and probably then we will have the emergency approval for using this vaccine for that younger age. In country, we don't have experience for vaccines for that young age because our national guidelines do not include that younger age. The next topic of discussion will be about the COVID positive mother-infant pair. And there's been a lot of concern around this area. And this was actually raised in a paper published in the British Medical Journal in March this year, which did a global survey among healthcare workers on small and sick newborn care during the COVID-19 pandemic. About more than 1,000 healthcare workers were interviewed in 62 different countries. And what came out was actually a concern in this younger age that more than half of these healthcare workers reported that some evidence-based interventions such as the kangaroo mother care were discontinued or discouraged just because the mother was COVID-19 positive. 2/3 of these healthcare workers reported that they did not allow mothers with confirmed or suspected COVID-19 to practice routine skin-to-skin contact, even when this was indicated, for example, in prematurity. 1/4 of the healthcare workers reported that they did not allow breastfeeding, even when, even by an infected caregiver. So it was just for them a blanket, because of COVID-19, breastfeeding was discouraged. More than 80% expressed personal fears or increased stress based on just managing neonates in the COVID pandemic period. Separation of mother and baby. COVID-19 mothers, more than 50% of healthcare workers reported that they were actually separating these two when the mother was positive. And when the status was unknown, testing had not been done, about 16% of them reported that they would actually separate the two. So what do we know? Are these practice evidence-based? We know that neonatal COVID infection is rare. We know that the rates of COVID infection in neonates do not appear to be affected by the mode of delivery, by the method of infant feeding, and that's where now breastfeeding comes into play, or contact with mother with suspected or confirmed COVID infection. So the issue of separation again. We know that the signs and symptoms common to many other, in a neonate with COVID-19 are common to many other neonatal conditions. So actually going clinically to try and separate who is a suspect becomes very difficult. The symptoms will be fever, lethargy, rhinorrhea, cough, tachypnea or difficulty in breathing, vomiting, diarrhea, poor feeding. When you look at this, a neonate with even transient tachypnea of the newborn or sepsis, they will all present with similar symptoms. So it becomes very difficult to clinically separate the two. Transmission to neonates, just like in the older population, is through respiratory droplets. There is some evidence of vertical transmission, still ongoing studies around this area. What was done in this study, they looked at about 900 COVID-19 positive neonates, and from their analysis, slightly more than 3% were sort of attributed to vertical transmission. But again, this is something that studies are ongoing. What we know for sure is that the transmission is still through respiratory droplets. So based on this, some general guidelines, all newborns born to mothers with suspected or confirmed infection should be considered the same as suspected COVID-19. So the issues of isolation comes into place. Testing to this should be done. And as you are testing, you should be, the guidance is that this testing should be done 48 hours post-delivery. And you should be consider the fact that a test might be positive just because of contamination from maternal secretion in the nasal pathways of this younger age, or negative because the immune response has not happened at this early age. Remember, we are saying transmission is mostly post-delivery through droplet. Rooming in with strict IPC measures is strongly encouraged. So the mother should have their mask, should practice hand hygiene, but separation should not be the practice. Breastfeeding should be encouraged. And then most importantly, the same rules that apply to the isolation or considering this person not to be infectious will apply between the mother and child. So a mother who has satisfied the national protocol for the isolation should not be considered infectious to the neonate. So they should, that is a consideration to have in place. Just to mention that all these considerations were put into place when the national protocols were being reviewed. Dr. Anne-Marie was part of that team, was doing that review. So these are part of what is considered in the national guidelines. Not recommended face masks on neonates. And remember, this also applies to children below 2 years. Plastic infant face shields, again, not recommended for these neonates. We talked of discontinuing high impact evidence-based interventions such as skin-to-skin care. Routine separation newborns from their mothers, again, is not recommended. This should only happen when separation would be indicated even for a non-COVID case, for example, where the mother is critically sick or the child, the newborn is critically sick and required NICU care. So thank you so much for listening. Back to you, Dr. Anne-Marie.
Thank you very much, Dr. Chaby, for that presentation. I think the issues you have addressed are common questions. A lot of panic around COVID positive mothers, with us extending our vaccination and having sicker children, whether children should be vaccinated. So thank you for covering those areas quite ably. I think we still have a few questions, a bit of time for the Q&A. So I hope all the panelists are on board. Okay. I will address the first few questions to Dr. Reel. Dr. Reel, what is the role of aspirin in management of COVID? I know you talked about it in MISC. I know I've also been asked this question by physicians because they say aspirin is not really an anticoagulant like the low molecular weight heparins. So why do we give aspirin to our children? Thank you.
So I think the aspirin would be for specifically the MIS-C syndrome. And I believe it came out from the Kawasaki's literature, given the close relationship with which they present. And from the, if I'm, I might be making this up, but I think because of the Kawasaki's disease thrombocytosis and activation of platelets, aspirin was started in those cases. And kids with Kawasaki's disease on aspirin have a less likelihood of developing coronary aneurysms. So I think those two factors of activated platelets and the risk of coronary aneurysms is why for MIS-C I would specifically put aspirin. And I'm not sure if it came out in my my study, in my talk, but the recommendations to continue the aspirin for at least 4 weeks. So yeah, I hope that answers your question. It's really for that thrombocytosis and activated platelets that we've seen in Kawasaki's and the aneurysms.
Thank you very much, Dr. Reel, for that response. And I think it's a bit clearer. I do see questions here on the role of remdesivir, which I believe you addressed. Somebody else has asked, is there any role for ulinistatin? I don't believe there is, but perhaps you can just address this because that's one of the drugs that is being touted for use in adults.
Yeah, so I think there is some literature through the recovery trial again for its use in adults. Again, we don't have any literature in children, and I'd be very reluctant to use it, to be honest.
Thank you. One last question that could possibly be addressed by you. Could hepatitis be related to the likely overuse of paracetamol or related analgesics before children are brought to hospital?
Yeah, I think so. I think we have to be careful with the use of paracetamol. I think if you're within the range and yeah, within the dosing range and dosing period, and it's not overdone for long periods of time, I've never seen it cause it if you're in the right range. Could it if you're giving too much and for a very, very long period of time when you have other insults to the liver? Yes, but that would be rare, I would think, especially if you're in the right dosing range.
Thank you, Dr. Ree. Do you want to make a last comment on the role of vitamin C and zinc, which we know we are seeing in a lot of prescriptions coming out of our outpatients for management of non-severe children or even severe disease in children?
Yeah, I mean, I think if you look at all the evidence, like I said, it's a virus. I don't think you need to give vitamin C or zinc. I think, you know, some of the vitamins, it's not bad to have vitamin C, but would I give a prescription specifically to a child who has COVID? No, I don't think there's any good evidence for that. And I truly don't think it makes any difference. And we should probably, I don't like to give my own kids anything extra that they don't need. So yeah, just a normal supportive care without giving any extra is what I would recommend. But I'm ICU, so I don't have that outpatient experience that others do. But thank you.
Thank you. Please remain with us for a few minutes for our closing remarks. I'd like now to get into the questions regarding vaccination. I believe some of these questions have been addressed, but I'll just put some to you, Dr. Chaby. Is there any role for AstraZeneca, or rather maybe is there any data regarding AstraZeneca use in children? That's the vaccine we've had readily available in country so far.
So the vaccines that are mainly approved for children are the Pfizer. For AstraZeneca, there was a trial that was actually halted 3-4 months ago because of some safety concerns. So it has not yet been given the emergency approval for use in children. But as I said, a lot of studies, a lot of trials are still ongoing. So we'll see more and more of these vaccines being approved for children as the evidence or as the safety and efficacy, effectiveness becomes available. So at the moment, there was a study on the AstraZeneca vaccine, but it was halted due to some safety concerns.
Somebody else has asked, and I can see similar to some of the questions we were getting, and it shows that there's a lot of vaccine hesitancy out there, similar like there was for adults. The question is there any data on vaccination in children? I believe you've addressed that, but they're asking, can MIS-C result from vaccination?
So there's a lot of data on the vaccines that have been approved. And on one of the slides, I've actually put a link on the review memorandum by the CDC, which compiled the available evidence at that time on the safety of vaccines and the kind of side effects that were being observed. MIS-C was not one of those that was observed. So at the moment, there's no link. I would encourage all of us to follow that link and look at what was available in terms of information on the side effects that were experienced.
Thank you, Dr. Chaby. I know that this question has been addressed in the adult forums, but I can put it again to you. How safe is AstraZeneca in pregnant women and those who are breastfeeding?
So this has been approved for breastfeeding and lactating and pregnant mothers. I've also seen a question on timing. What time is it best for the pregnant mother? The recommendation is that actually any time, and if possible, even the one who is planning to conceive should be the one getting the vaccine, but the vaccine can be given anytime during that pregnancy. Recognizing that pregnancy poses a risk for more severe disease, for more likelihood of infection.
Thank you, Dr. Ri. Is Dr. Christine Karanjachege still with us? Okay, Doc is not available. So there's one long question here that may be one of the last that we're able to address because of time. Dr. Ri, you're with us? Doc, please unmute. Okay, so somebody has asked, my daughter, 16 years old, had COVID-like symptoms, saw a doctor and put on meds. I don't know what meds those were. And they were told testing was not necessary since the management would not change. And she recovered after 3 days. 10 days later, we had symptoms and both parents were positive. I feel that my daughter should have been tested. And the family would have been more cautious in isolation measures and avoiding spread. It was hard to tell if she's the one who infected the family since no test was done. With that, I feel that testing for children is necessary so that you don't claim they have COVID or treat them as if they have it, since it amounts to stigmatization and psychological trauma. I know a lot of my colleagues who are working in our outpatients are here on board. We have been seeing an increasing number of children presenting with upper respiratory tract infections. We know it is also our flu season. If I get particularly older children, school-going age, there are rapid tests now available. I don't know that I would subject every single child to the expense of a PCR, but if a rapid test is available, I agree with you, it may help in terms of the family being able to be more cautious and isolate. And there are concerns right now about children who are in schools and even boarding schools coming back and spreading to vulnerable people in the household. So we don't have all the answers, but I think if a rapid test is available, if cheap tests are available, it would make that a lot more accessible than making every child actually have a PCR test. But the message is also that we should vaccinate as much as possible, because that is the one sure thing you can do in addition to all the other measures to reduce the risk of transmission. So I'm now just going to ask all the presenters just to give their final remarks. I'll start with Dr. Reel.
Yeah, I would say, I think be vigilant about MIS-C, and then think about IVIG and steroids in terms of treatment. For your acute COVID, I would say that a majority of the patients, I suspect, are not having their symptoms from the COVID necessarily. Yeah, supportive care for acute COVID, IVIG and steroids when you thinking about MIS-C, and don't miss MIS-C, because I think that's the treatment works very well and very quickly. So thank you.
Thank you very much, Dr. Reel. Dr. Chaby?
Yeah, thank you. Two things on vaccination. Children do get sick, and children can be source of infection to their family. Actually, that relates to the question that Dr. Anne-Marie has just read. So as more and more vaccines become available, this is a population that we may consider giving the vaccines. On the mother-infant triad, we risk the danger of reversing the gains that we had gained on neonatal morbidity and mortality due to this pandemic by starting to do things that are not evidence-based. So we really need to keep to the guidelines and work based on evidence and not what we feel. So this is an area that we really need to keep an eye on. Thank you.
Thank you very much, Dr. Chaby. Dr. Christine, are you able to give us your closing remarks?
Yes, thank you, Anne-Marie. Unfortunately, I haven't really been able to follow all the presentations very well, but I have been hearing here and there. So what I would be my emphasis is that for COVID-19 in children, we really have to have a high index of suspicion, and just use treat what the child has presented with, first of all. If they come with a GE, treat the GE. If they come with a respiratory infection, treat the infection. Based on the severity, admit, treat the child for whatever they have come with, because sometimes it's really hard to differentiate between the incidental findings and the actual COVID. Right now, as I'm sitting here at my desk, I've just seen a child with a very low white cell count, more of a lymphocytosis, low platelets, and those are some of the parameters that would make you feel like I have to investigate this child further. So let's have a high index of suspicion. Let us not even be shy of telling the parents that I suspect this could be it. And again, to emphasize, let the adults in the house get vaccinated. Thank you very much.
Asante sana, Christine. Dr. Maureen?
That's fine, do it, then you tell me, yeah.
Dr. Chege, please mute yourself. Dr. Muchella, your closing remarks.
I am humbled to have presented the case, and I have learned as much as everyone else what we would have done differently, and we are definitely looking out. We are lucky that the Delta variant has not caused much havoc among children, but we are grateful for the opportunity.
Thank you very much. In closing, for myself, I just want to reiterate that part of the supportive care that we're giving to children should not include antibiotics. I think our prescriptions of azithromycin have really shot up, as well as all these other additional things, the multivitamins and so on, for otherwise healthy children. I'd also really like to thank my fellow presenters for being available, availing themselves at short notice and coming together to make this presentation a success. So I appreciate you all. I appreciate the attendees who have come, and I hope it has been a useful session for everybody. Thank you very much. I'll now hand over to Dr. Thuranira to close this session.
Thank you so much, Dr. Anne-Marie. So thank you so much to the 900 plus that logged in today. We had a nice time. We enjoyed the presentation. To all the presenters, thank you very much. Next week, we are hoping to start a 6 weeks or 7 week series on COVID-19 and pregnancy. Talk about the myths, the perceptions, issues of breastfeeding, issues of vaccination, delivery, patient experience. We have people willing to tell us the story, and it will be in a bigger platform. We'll announce much more. We'll have partners from our neighboring countries, and thank you so much. So looking forward to having you from next week on Friday, and have a good day. Enjoy your Friday, enjoy your weekend. Say hi to your people, stay safe, wear your mask, social distance, sanitize, and get vaccinated. Asanteni sana. Thank you.
Thank you.